So welcome for those of you joining us today. Welcome to CrimCon, our first ever virtual conference. My name is Dr. Brianna Beaupre. I'm an assistant professor at Wichita State, and I'm also a board member for CrimCon. And we're super excited to be having this conference. We've had over 300 presentation submissions, and we've had really great presentations so far. So thank you for joining us. Just a few things to keep in mind. Okay, so this is a little different because it's a roundtable. So the panelists are going to introduce themselves to you. They're actually going to have a full 45 minutes, and then they're going to leave 5 minutes for Q&A for you to answer at the end. And so if you are an attendee, this is what it should look like on your end. Please ask questions in the Q&A box. And just remember to have fun. We started CrimCon to be something different, something fun and inclusive and accessible. So we're very happy to have you all here. And with that, I'm going to turn it over to the panel, which is entitled Simulation Applications for Forecasting Effective Responses in Corrections, SAFER-C, and COVID.
Great, thank you so much, Bree. Welcome to our roundtable on the simulation applications for forecasting effective responses in corrections, or SAFER-C model. My name is Jessica Dockstader, and I'm a research specialist at CNA, where I spent the last 6 months working on the SAFER-C model with our team. During today's discussion, we're going to discuss how SAFER-C was developed and what makes it unique, why it's beneficial to correctional facilities, what came from using it in the Minnesota Department of Corrections, and the future for SAFER-C. But first, let me introduce you to our speakers. Dr. Rebekah Yang is a systems engineer at CNA with 3 years of experience supporting the Federal Aviation Administration. Dr. Yang has experience conducting technical analysis and research regarding aviation information exchange models and their governance. Dr. Yang also supported the FAA in the development of an unmanned aircraft systems traffic management program. In addition, Dr. Yang has 5 years of experience in transportation infrastructure, and specifically the cradle-to-grave economic and environmental analysis of pavement systems. Dr. Chip Coldren is the director for the Center for Justice Research and Innovation at CNA. In this capacity, he oversees all center research, technical assistance, and justice system transformation activities, as well as center proposal and product development, training-related activities, and after-action analyses of critical incidents. He is the principal investigator for a national study of the impact of equipment modalities on correctional officer safety and for a randomized experiment with body-worn cameras in an adult detention center. Dr. Grant Duwe is the research director for the Minnesota Department of Corrections, where he forecasts the state's prison population, conducts program evaluations and research studies, and develops risk assessment instruments. Dr. Duwe is the author of 2 books, and he has published more than 70 peer-reviewed articles on a wide range of topics in corrections. He has designed risk assessments for a variety of correctional populations that predict outcomes such as recidivism and prison misconduct, and he is a co-developer of the Pattern, prisoner assessment tool targeting estimated risk and needs for the Federal Bureau of Prisons. Last but not least, Guy Bosch is the warden for the Stillwater prison. He has served 30 years in the Minnesota Department of Corrections. He started as an officer in 1989 and has held a variety of roles in the department and worked at 4 facilities in various roles such as officer, case manager, lieutenant, director of classification, interstate compact director, contract monitor for population of offenders held at private prisons in Minnesota, associate warden, and warden. So as I mentioned, we've been working on this for the last 6 months. With the Minnesota Department of Corrections, we've worked with 2 of their facilities, the Stillwater facility and the Faribault facility. The Stillwater facility is a closed security facility with 1,500 offenders and 550 staff. Our objectives during that period of time that we worked with them was to determine the impact of reinstating different activities such as full or limited visitation and work or volunteer programs. Our work in the Faribault facility was a bit different, as it is a medium security facility with 1,800 offenders and 675 staff. With this facility, we work to determine whether a post-incident evaluation of their facility outbreak could be used to validate our model. With that introduction to our work, I'll pass it over to Dr. Rebekah Yang to discuss the development of the model and what sets it apart from the others.
Great, thank you, Jessica. And as Jessica mentioned, I'll be taking the next 10 or so minutes to talk about the origins of the model and a high-level view of how the model works and some of the case studies that we performed with the model. So CNA actually developed a similar model for the US Navy earlier in the year to look at virus spread among ships and among sailors for the Navy. So we took the opportunity to adapt this model to the correctional facility environment, and that was the genesis of SAFER-C, which stands for Simulation Application for Forecasting Effective Responses in Corrections. So SAFER-C is an adaptation of this original Navy model to, again, the prison and jail facility environment. And as you can imagine, there are some differences between the models, as opposed to the Navy model that looked predominantly at sailors and the potential for virus spread among sailors. In the correctional facilities model, we now have two different populations. We have staff as well as offenders, and the staff potentially will introduce community spread into the facility, while the offenders will stay in the facility. So there are a couple differences there that we've adapted and used to transition the model to SAFER-C. So CNA has been working, as Jessica mentioned, with the Minnesota Department of Corrections to initiate this project, as well as to pilot SAFER-C at two facilities. And I'll talk about some of the results that we were able to see by doing so. All right, so I'll talk a bit about what the model, how it functions at a high level. So SAFER-C is a stochastic agent-based model. So Jessica, I'll have you start showing the slides as I introduce this. So that means that we track individuals, all of the staff, all of the offenders throughout all of their daily activities in the facility. So we've worked with the Minnesota Department of Corrections to collect quite a bit of information about each of the facilities in order to do so. So we collect a lot of information from each facility about the individuals in the facilities, as well as all of the activities that they participate in throughout the day, the organizational structure of the facility and the operations, as well as the estimated number of contacts that a potentially infected individual may spread and may interact with as they go about their day. So as you can see on the slide here, for some reason, I think it's only showing half of the slide, but we can see different transmission pathways for infected staff, infected visitors, and also infected offenders as they go throughout their day. So all of these transition pathways are taken into account with the SAFER-C model, and we're able to look at all of the different potential groupings and community aspects and organizational structure of the facility as we go through the model. So as I mentioned, SAFER-C is a stochastic model, which means that it accounts for uncertainty, mostly due to individual behavior, as well as uncertainty due to how the virus may behave through these random draws as we simulate each of the facilities and the different scenarios that we look at. So these uncertainties are categorized in a number of ways. So they refer to which offenders or staff might be infected, exactly which individuals these infected individuals will come into contact with, as well as the progression of the virus throughout an infected individual. So Jessica, if you go to the next slide. Right, we can see one of the decision trees that we use to determine how the virus may progress through the individual. So these are based on CDC modeling parameters. So we use these epidemiological functions to be able to determine how the virus might progress through an individual. For example, if they will show symptoms or not, or if the condition of their infection may progress to a more critical or even fatal result. So SAFER-C will run through all of these different inputs that we've given it, all of the different interactions and activities throughout the day for the determined time range, typically 90 days, for example. And it will categorize a range of outcomes by running the model thousands of times to ensure that we are able to obtain a representative range of potential number of infections and number of fatalities and number of pathway progressions for the facility. So this allows us to better understand the uncertainty by getting a range of different outcomes and to look at the range of outcomes that might come from the different scenarios that we are modeling. So due to the complexity of the model, as you can imagine, it requires quite a bit of input information about facility operations and policies and each of the individuals in the staff and offender communities and populations. So we were definitely very fortunate to work with the Minnesota Department of Corrections closely on this and to collaborate in this respect. So we were able to speak with the wardens of the facilities as well as some of their lieutenants and collect a lot of information that was needed for SAFER-C. So for the next part, I'll talk a bit about the 2 case studies that we performed with SAFER-C to pilot the program with Minnesota Department of Corrections. So the first case study was the Stillwater facility. So this was done early in the year, and the Stillwater facility is a closed security facility with about 1,500 offenders and 550 staff, which at the time, there were no detected cases of COVID back at the beginning of the year. So the staff was interested in determining the impact of what would happen if they reinstated some of the different activities that had been locked down at the early onset of the pandemic. So for example, we looked at what if scenarios, such as reinstating a full or limited visitation schedule, reinstating work programs, or volunteer programs. So as you can see on the next slide, we found that reopening the work programs had the largest impact, followed by volunteer programs, and there were less impacts from limited or full visitation. So we were able to present these results to the Stillwater staff, and they were able to use these results as part of their decision-making process as they're deciding how and when to open up the facility, which I'm sure they'll talk about in the coming parts of the panel. We also looked at specifically the self-isolation policy that was in place at the facility. If you move to the next slide, Jessica. The original policy was a 7-day isolation period. And from our baseline case that was conducted over 90 days, we saw that about 90% of the cases had 824 potential cases within those 3 months, again, if nothing changed in the policies of the facility. And if we increase the self-isolation period to 14 days, we saw a potential decrease to 707 offenders that were getting infected in the simulated iterations that were run. So these types of different sensitivity analyses or different scenarios that we enacted gave us insight into how the virus spread would be impacted based on different policy changes as well as different operational changes at the Stillwater facility. So our next case study was with the Faribault facility. And this is a medium security facility with approximately 800 offenders and almost 700 staff. So in mid-summer, they did experience an outbreak of about 200 offenders in the May to June period. And we were interested in taking the information that was collected due to that event and conducting a post-incident type of analysis on the Faribault facility to see if we could use that to validate the SAFER-C model. So as you can see on the next slide, in the timeline here, we were able to run SAFER-C for the expected number of iterations. And we were able to see trends in the number of infections that correlated and corresponded well to the reconstructed timeline of events. So as you can see, we were able to clearly see the association of the different cases that increased, as well as what occurred when lockdown began and weekly testing was initiated, as well as spikes in cases as we started to reopen up the facility as would be expected due to community spread. So with this case study, we were able to validate the SAFER-C model, as well as discover new insights where we are able to identify hotspots as potentially vulnerable populations using the very detailed outputs from SAFER-C. So overall, this showed the importance of also having SAFER-C with very specific and accurate inputs, as well as the impact of community spread that we were able to analyze more deeply with this model. And we saw that that was definitely a factor in the number of infections and something that should be looked at further. So as you see on the next slide, we also looked at a specific case in the Faribault facility where the yard was reopened in July after the number of cases had decreased significantly. So we looked at what would have happened if the yard was actually reopened a week earlier or 2 weeks earlier, where there was still a significant number of cases. So we found that in 80% of the simulations that were run, the original number of infections were around 276, and that would have increased to 352 if the yard was opened a week earlier. And if it was opened 2 weeks earlier, we might have seen something closer to 426. So these different scenarios and analysis that were done can help provide some insights into some of the timing policies for the future. All right. So those are the two case studies that we conducted with SAFER-C. And with those case studies, we do have to point out some of the challenges of SAFER-C in terms of the model needing a lot of information. It's very data driven, which is a good thing, but also data heavy. So it requires a lot of expert knowledge of the facility and the inputs that are needed. So we are fortunate again to work directly with the Minnesota Department of Corrections to do so. Another challenge is the changing knowledge about the virus. So as many of you know, as this year has progressed, we have learned more and more about the virus, and different parameters have changed. So we've attempted to keep up with the latest research and update our inputs as we learn more about the virus. But that is definitely something that is a challenge for SAFER-C in any model that is looking to simulate virus spread and behavior. And finally, with the model being stochastic, this can result in small changes potentially propagating throughout the model and affecting the results in unexpected ways. So doing a sensitivity analysis or some of the what-if scenarios that we've performed with some of the case studies are important to looking at what the effects of some of the inputs might be on the output, and just better understanding how the model operates. So I hope that gives you a better idea of the overview of SAFER-C and some of the case study results and findings that we obtained, and also some of the challenges of using the model and that we've learned so far. So at this point, I will turn it over to Chip Coldren to talk more about why this model and the data-driven guidance was needed at this time. Thank you.
Thank you so very much, Rebekah. Appreciate that presentation. And I think I'll just say, by way of introduction, my chief contribution to this project was to develop the acronym. So I came up with SAFER-C. And I think, you know, all the heavy lifting was done by Rebekah and Guy and Grant, and we very much appreciate that. I'm just going to say just a very few words about why we think this model was needed, because it should be, I think, readily apparent to a lot of people that, you know, the looming COVID crisis was coming, and it was coming to corrections. And very soon after we learned about the existence of the disease, the folks in corrections were getting, you know, real-time experience with the impact of this disease. And so they did not, at the time, they didn't have the tools that they needed to develop, responses and to manage the disease that were unique to their particular facilities and their particular operations. So we know that there were other disease spread models and disease prediction models that existed, but to our knowledge, none of them operated at the facility level, and none of them gave people in the facilities the information that they needed to take specific actions to mitigate the problems, or as Rebekah has pointed out, to assess the efficacy of certain policies and practices in response to the model. So that may be one of the most important things that was needed. It's not just that people needed ways to understand the spread and manage the spread, but they needed ways that they could tailor to their particular crisis that they were experiencing at a certain time and place. I'll also say, at the time in Minnesota, there had been a state audit report on corrections that had recommended that the Minnesota Department of Corrections increase its incorporation and utilization of data-driven decision-making. And so they saw this actually as an opportunity for doing exactly that and demonstrating that they were in fact a data-driven organization. And so we think that this contributed to that as well. But my most important point about the need for this type of model was that something was needed concretely to contribute to problem management that made use of the available data resources that existed in the Minnesota Department of Corrections. So with that, I'm anxious to hear what Guy Bosch has to say and his perspective on the need and the importance of this model. Thanks, Guy.
Good morning. I'm a warden at the Correctional facility in Stillwater, Minnesota. It's a 1,600 bed facility. It's 114 years old. It has 5 large cell blocks that house about 250 offenders a piece, and it's the tiers and the galleys that go up 60 feet in open cells with bars. There's a newer segregation unit, a treatment unit, and a minimum unit. We came into this at Stillwater kind of on the front end. It gave some credence to an awareness. We get a lot of initiatives in corrections, and we pick through those, and this one gave some credibility to what we were going to see with COVID. It helped us on the front end create a new normal. We were very nervous about the things that had to be done in corrections to mitigate risks, such as shutting down our dining room, shutting down our visiting, shutting down our volunteer services, shutting down our recreation centers, shutting down our barbershops. The easiest decision would have been made just to lock the facility down. But in retrospect, that would have meant that 1,600 guys would have been locked in their cells for 9 months now. And that's just not what we can do. So it helped us create a new operation for a dynamic and complex organization such as a prison with 1,600 offenders. It helped us prioritize our objectives, to look at health services, behavioral health, mental health, recreation, visiting, things like that, and to bring them back at appropriate times helped us highlight risk and mitigate those risks. We still don't have our dining room open because of the risks that would have caused, but we have opened up other things. We were able at Stillwater to open up visiting at certain points of the pandemic, and that's critical to the offenders that we serve. Contact with their family. These offenders are dads and brothers and fathers, and to get visiting to come in and know that that's not going to spike a risk is reassuring to staff. It also is reassuring to the offenders that we're just not giving up and walking away. We're fully engaged and fully doing everything that we can in creating this new normal. We made a lot of decisions in the last 9 months regarding how to operate Stillwater based on what we learned from SAFER-C. I thought about it every day. It helped us develop our quarantine system. It helped us develop how we manage our work assignments, how we cohort offenders together, how we recreate together, how we basically do everything in the facility under a new model of controlled movement, and just take as few risks as possible. So did it work? Did the conversations work? Was there value in talking through the SAFER-C model at a facility like Stillwater. It's 114 years old and 1,600 close custody offenders. I guess the proof is in that up until October, we never had a COVID offender case at Stillwater. Out of 9 large correctional facilities in Minnesota, Stillwater was the only one that never had one single offender COVID case. People were astonished by that. You know, like, what's going on in Stillwater? They haven't had one case. Other facilities were ratcheted up. And I said a lot of it had to do with the staff and the offenders engaged in controlling this pandemic. And there's a little bit of luck in that. But the SAFER-C model really had a high percentage of why that occurred. So we were able to run our facility pretty clear for the last, since March up until October. We were one of the only facilities that was able to reopen visiting, and those experiences with the offenders visiting with their significant others is impactful. It kind of brought us together with the offenders. They were like, we're in this together. It's the officers and the offenders fighting this enemy of COVID, and we kind of engaged and brought us together, and we were all in this fight together. Come October, we got 1 case that came in, and then we had 2, and then the Midwest got hit with just an uncontrolled surge in COVID-19. So we went from in 2 weeks we went from 0 cases to about 900, and that just highlights how fast this moves through. Then we were chasing COVID, and we chased it down, and we got about 400 guys that never got COVID, and now we're starting to open things back up with past positives. We're opening up our work assignments just opened up today. So it allowed us to move through wave 1 of COVID. It allowed us to move through wave 2 of COVID. Wave 3 was just too much for a 114-year-old facility, but for us to fight it. But the tools that we learned and what we did create opportunities to slow it down, to make sure it didn't wipe out our entire facility, to make sure it didn't wipe out all of our staff. And we did go a long time with having no cases. I truly believe that without the conversations that I had with SAFER-C in the early stages, that Stillwater would not have been able to go from March to October without one single offender with one single infection. And once it did hit, we started cohorting, we started doing the things that we talked about. If it comes in, it wasn't ever a if it comes in, it was kind of a when, and we held it off for a long time, and that's a credit to Chip and his team. So I'm very fortunate at Stillwater. It gave the staff and offenders, kind of a morale boost that we're using data to make decisions, and this just isn't a bunch of corrections folks sitting around a big table and guessing. This was very strategic. The decisions we made, it had weight and value to it, and it helped with the buy-in. When you manage a complex organization, the buy-in of the offenders and the staff is critical. So I mentioned this model at almost every big staffing briefing that we're working on this, and we're using this model. We have experts and developing a data-driven decision tree. And that really gets buy-in, and then that buy-in just multiplies exponentially for everything that you launch after that. Compliance with mask wearing, compliance with social distancing, compliance with hand washing, because they know that we're doing everything we can. So it was I would say it was a huge success at Stillwater. We'll look back at some time on this and dissect all the decisions that were made, and SAFER-C model was in every one of those, and they are going forward now with the outbreak that we just had. Appreciate all that. Thank you.
I was muted. I believe that now we'll hear from Guy and also from Grant on what came from using the model what you're able to learn and how you will use this type of data in the future. So welcome, Grant.
And good morning. So I think it's helpful to kind of provide a little bit more background to this project, at least from the Minnesota DOC perspective. When COVID emerged in March, it became very apparent to us right away that this was going to pose a serious safety issue for not just staff, but also, inmates in our facilities. And one of the things we tried to do right away is to kind of get a sense as to what the impact of COVID would be once it was introduced within our facilities. And there are other simulation models out there. And before we started partnering with CNA, we actually did experiment with one of these simulation models, which is important to point out requires much less data than the SAFER-C model. And some of the initial results indicated that nearly everybody in prison was going to get infected with COVID. And not just that, with our information that we had at the time, that we would be looking at more than 100 fatalities by the beginning of July. And that was very sobering. Fortunately, that hasn't occurred. But I think, what some of the folks have touched on previously is with COVID, you're really trying to balance risks. You can, as Guy mentioned, you can completely shut everything down in an effort to stamp out COVID and to make sure that no one gets it. But at the same time, if you lock everything down and everyone is in their cell for 24 hours a day, 7 days a week, then you're going to be introducing other risks. What kind of impact does that have on the mental and physical health of the people who are in prison? And so what we wanted to do as an agency is to try to identify a way that's driven by data to help us make decisions where we could better balance those risks, rather than a binary shut everything down or just keep operating as is. Let's try to thread the needle and come up with an approach where we may not be able to operate as we did prior to March, but operate in a way where we're balancing risks, where we're still providing people in prison with most of the opportunities and programming and services that they had before COVID, but also removing some of those things that may elevate the risk too much. And so when we started partnering with CNA and the initial model was created, I believe it was in May, I remember one of the interesting findings was how little of an impact things like limited visiting, volunteers, how that the limited impact that would have on the rate of infections, assuming that it was introduced into Stillwater. And I think that provided agency leadership with a little more confidence that we could, at least at that time, back in May, everything was locked down in the state. That once we started to see numbers recede a little bit, that we could start to open things up a little bit. And that's what we did at Stillwater. And but what was interesting is at the time, and Guy mentioned this, that Stillwater didn't have a single infection until October. So the model that CNA developed, while it was great and it helped with decision making, from a research perspective, we were still curious as to as to how accurate it was once infections were introduced into the facility. And what I can say now is when you look at some of the slides that Rebekah introduced earlier, there's one about that shows the results from the 10,000 iterations of the model, and you'll see most of the models suggested that the number of infections at Stillwater would be close to 900 after 3 months. And what we saw when COVID was introduced to Stillwater in early October is, after it didn't take 3 months, but after about a month, roughly 900 or so of the people at Stillwater ended up getting infected. So the model was relatively accurate there, and also because we wanted to have some indication of how accurate it was at another facility, we CNA developed another simulation for the Faribault facility. And when we compare the model's performance with actual data there, it does suggest that it was relatively accurate. And so I think even though there's a cost in terms of increased data for the model relative to some other simulation models, I do think that you do get a greater benefit in terms of the accuracy. And again, this is important when it comes to making decisions where you're having to balance risks. And I think, we've seen that at Stillwater, but then I also think we've seen that at some of the other facilities. So, and Guy, I don't know if you want to jump in on that.
Well, I think it's important that when COVID came into Stillwater in October, balancing the risks, we slowed it down when we were doing our sentinel testing every week. That it was a month draw up instead of like a fire through the facility. I mean, it was fast and significant, but I think we were able to use the cohorting through the model and kind of get around it relatively quickly. So, we're 6 weeks from our first COVID case. In 6 weeks, we went from 0 to 900 to 2 active cases now. So it allowed us to manage through that relatively quickly. So instead of locking guys in, like you said, and taking away everything and creating other risks of violence and mental health issues and everything that goes along with that and health service issues, once it came in, we went from 0 to 900 to 2 in 6 weeks. And now right now we're opening back up. So it allowed us to kind of get through it very quickly and make decisions so that it wasn't a 3-month draw where we were locked into this medical lockdown for 3 months. Even a month of lockdown is significant for offenders. It's rough. I mean, a month locked in your cell, getting out, 20 minutes every 3 days to take a shower is that there's a lot of problems with that. So this allowed us to move through really, really quickly.
Well, thank you so much, Grant and Guy. And, we'd like to close out today hearing from Dr. Coldren and Dr. Yang about the future of SAFER-CTM. Chip, I'm sorry, you're muted.
Got it. Okay, I'm here. Jessica, thank you very much. And I just want to offer a special thanks to Grant and Guy, not just for their participation today, but for the working relationship that we've had over the months. And I think, in terms of the closing and the future of all this, I think there's one thing that's very clear, that there are trade-offs, so and the trade-offs have to do with the data and the level of effort required to develop and build a model like this, and the options that the model provides for decision making. So as Grant suggested, there are other models that are out there. They operate at a more aggregate level, not so much at the agency-based level or the agent-based level. And they may provide results more easily and quicker, but they don't necessarily provide the level of detail, as I suggested at the beginning of this session, the level of detail that a correctional administrator needs and strongly desires to make important decisions. So that's kind of the story about the future of this. I think we need to find ways to mitigate or ease the data requirements and the level of effort required to get a model up and running while maximizing on this individual based utility that the model has. And so I think, Rebekah can say a few words about that, but it really has to do with making the model more user friendly while retaining its primary benefits. The other thing I would say is that I can just see, and I think I would get some agreement from others on this, that this model doesn't have to be limited to the spread of viruses and diseases. If another sort of pandemic came along, well, we have something that can be used. But in my understanding of what happens in correctional facilities, if you wanted to model and get greater control on issues like the spread of contraband through a facility, the spread of violence through a facility under certain conditions, or even the spread of things like rumors and communications, I think this model can be applied in other settings and to other problems. And so that's the kind of thing that we're going to look at in the future. And I'll ask Rebekah to say a few words too, since she's been so close to the model development effort here. Rebekah?
Hi, I'm not sure if you can hear me.
Yes, we can.
Okay, perfect. Yeah, I think my internet has some problems, but I think that's definitely right. We've been working throughout the year to try to make the model more flexible. At the beginning of the year, we really were just trying to push out something that was usable and that would give accurate results. So over the last couple months, especially as we've been validating with the second facility, the Faribault facility, we've tried to incorporate more flexibility into the SAFER-C model so that it could be very easily customized to different types of facilities, so that SAFER-C could be used potentially for many more facilities in addition to Stillwater and Faribault. So I think we've been making some progress on that. And as I mentioned, there are still some challenges definitely with a tool like this that takes a lot of information, is fairly complex. But we've been working through some of these issues and hope to continue developing the model and the research that goes into it as we go along. So I'll just add that there.
Great, thank you. I think that's it, Jessica.
Great.
So you all,
So we'll go.
you can open
Thank you, Bree.
Q&A now if you'd like, or whichever.
Yes. Yes, I was going to pass it off to you, and we'd like to open it up for questions.
Perfect. I will say, while people are typing, I really appreciated your attention to involving families and the focus on not just locking down. I'm doing a research project on the impacts of familial incarceration during COVID, and it's very important to keep family ties. So just wanted to point that out. Attendees, are there any questions? So I'll give it maybe another minute, and then if not, we'll go ahead and close out.
Okay, great. And if there are no questions, we really appreciate the opportunity to discuss the SAFER-C model with you today. It really was in my opinion, a great partnership on behalf of CNA and the Minnesota Department of Corrections. And again, I just want to thank, Dr. Chip Coldren, Dr. Rebekah Yang, Dr. Duwe, and, Mr. Bosch, just for joining us all today. I know it's a very busy time during the pandemic, and, we all have competing responsibilities, but I think that presenting on this work, and informing other correctional facilities of the partnership, can really be beneficial. So thank you very much.
Great. Well, if there aren't any questions, I will go ahead and close out. But thank you, panelists, for coming today. This was a great presentation, great discussions, especially about, the impacts of early intervention about COVID in prisons. So thank you very much.
Thanks, everybody.
Thank you. Bye-bye.
Have a great day. Thank you.
Everyone.
Thank you.